Hi, I'm TDavis. I'm Senior Manager for Demand and Community Engagement, and this presentation is on demand and community engagement for reaching zero-dose communities. I've been working with Gavi in this demand and community engagement role since March of 2023, but I've worked in social and behavior change for about 3 decades. I want to discuss with you today about some issues that I'm seeing in terms of in terms of applications to Gavi, a key information gap that I've recognized, and how we can resolve it. First, here's what I'm seeing after having reviewed about 12 FPP and EAF applications to Gavi. I'll give you a quick overview, but then I want to return to the first two, which I think are very important for this community of practice. So first of all, I've seen really spotty use of behavioral and social drivers surveys. There's a lack of congruence often as well between the behavioral and social drivers findings and the demand and community engagement interventions and activities are chosen. So we have tools to be able to know what are the drivers of vaccination in different settings, and yet that the tools are not being used enough. And then even when we have the data from it, sometimes what is being done, the tool being used doesn't really match the problem encountered. Secondly, communication channel reach and preferences are sometimes derived from national surveys, for example, of BEST or behavioral and social drivers data, with little data on key zero-dose areas like fishing villages, island communities, and pastoral nomadic communities, urban informal settlements, and so on. So demand interventions and activities are not adopted or adapted to those areas. Third, some countries latch on to one demand tool and really kind of overdo it. So I've seen this in particular with human-centered design, and they don't really provide clear capacity building objectives for that work. There's not enough follow-up in terms of, well, if you do human-centered design, what actually you're designing? Do you have funding to be able to then move something forward to actually advance demand from that or not? Some countries attempting to use service integration and to fund primary healthcare platforms, and that's good. But the independent review committee is not always convinced of the value despite the data on reduction in zero dose. This can be a key for social behavior change and demand coverage is to be using these platforms. So we need to do more to convince them of the value of it. And responses to service experience issues, such as having a poor experience when you interact with healthcare workers, is often limited to plans for interpersonal communication training, and they don't mention an evidence-based curricula for doing that or other options, such as just like changing health facility hours. And engagement of religious leaders and community leaders is done by some, but without mention of an evidence-based model or approach. For example, the Channels of Hope model is evidence-based for doing that, but sometimes they just say, we're going to talk with community leaders or religious leaders and about the importance of vaccine. This is a Gavi demand and community engagement theory of change that I developed based on the behavioral and social drivers or BESD framework developed by WHO, UNICEF, and Gavi Alliance partners. Note that the elements in the yellow, green, and blue boxes are drawn from the published literature concerning what we have found influences vaccination uptake. However, many of the studies used to put this together were from high-impact countries, so we still need more studies to know which of these affect rates the most in lower and middle-income countries. At this point, it appears that the blue box, the practical issues, and the green box, social processes, have the most impact, and that the yellow think and feel box has less impact on vaccination rates. This is a framework, and if you look here, these are the activities that we should be conducting to affect each of these things. Starting the one that is often the most important, resolving practical issues, we can make improvements here by using BES data through service experience interventions, through interpersonal communication training of health workers, including community health workers, and through improvements in health facilities and supply chains. And this improvement in health facilities include things as simple as just having a comfortable place to sit. And okay, for social processes, we work to build social norms around vaccination by having trusted religious and community leaders promoting vaccines, by training community health workers in interpersonal communication. It actually fits under both boxes. But by focusing in particular on having health workers recommending vaccines and making vaccination the default as part of that interpersonal communication, and through gender transformative interventions. The thinking and feeling box, in that we often work on increasing people's perceptions of their susceptibility to vaccine preventable diseases and the severity of them. And by increasing their confidence in vaccines, their beliefs that vaccines work and that they're safe. And we do that by basing counseling on the behavioral and social drivers and determinants found in an area, by targeted reach via traditional and social media, and through social listening and digital outreach. This is also the target of behaviorally informed interventions. There are a few other interventions that can be useful in zero dose areas to increase demand. Through Gavi's SFA funding, testing is being done on demand side incentives to address immunization challenges. This is where one offers food, products, cash, those sort of things to incentivize vaccination. An earlier study by Banerjee in India, for example, found that offering mothers 1 kilo of lentils each time they brought their child to immunization and a set of plates when they completed vaccination had a great impact on full immunization, but it did not seem to affect zero dose. Testing DSIs in these 4 countries may find different results, though. And also, a recent gray literature analysis found that the use of the care group approach resulted in large increases in full immunization and 12.5 and 9.2 percentage point better indicator gap closure for DTP1 and measles vaccine coverage, reducing zero dose children, when comparing the care group approach projects to other child survival projects not using that approach. And an earlier published study by George in 2015 compared care groups and non-care group projects. And the care group projects outperformed non-care group projects for tetanus toxoid 2, that is 16-point better gap closure, and measles as well at 9 percentage points. And also other indicators like exclusive breastfeeding, complementary feeding, vitamin A, and 9 other health indicators. DTP was not evaluated in that study, though. So we have a great tool that helps us to look at all of these potential drivers and determinants of vaccination called the Behavioral and Social Drivers Survey, or BESD survey. And if I had one thing to recommend in terms of improving vaccination demand globally, it would be to use this survey tool, not just at the national level, but at subnational levels and specifically in zero dose communities. And then to base high coverage, evidence-based demand interventions that address these determinants that you find. The 5 indicators on the right were chosen as the priority ones, and these are the questions related to those, which I won't go through right now. These help us to sort out what are the things which are most important. Sometimes people think it's all about motivation and intention, and that people who don't vaccinate their children are simply not motivated. But that's really too simplistic. Let's remember that one's intention and ability to vaccinate their child is influenced by a host of other things, and that it can vary by region and area, of course. However, I do feel like there's a limitation in the way that this behavioral data is often analyzed, and that we could do more in that regard, especially in terms of knowing what the drivers of underimmunization are in zero dose communities. So let's look at an example that may take you back to your graduate school days to illustrate this. Let's say that 100 conference participants were served lunch and 5 developed food poisoning shortly afterwards. How would we tell which of the foods were served caused the illness? Well, let's say that 70% of the people had the chicken, 20% had the beef, 10% had the vegetarian option, and then there are other foods that they ate as well. Well, since the most people had the chicken, it must have been the chicken that's the problem, right? Well, no, that's not how epidemiology works. And maybe we should just see how many people got sick in all of the other cafeterias across town. Well, no, actually adding in data from all the other cafeterias might make it hard to sort out what was the cause in this cafeteria. So we don't just look at the most common thing that people said, and not everyone who eats a particular food that's contaminated will necessarily fall ill. So how do we decide? Well, the way this is traditionally done is looking for correlation between the foods eaten and the illness using an odds ratio. So if we found that 4 out of the 15 people who ate potato salad got sick, but only one of the 85 people who did not eat it got sick, that would help to make the case for the potato salad, that the potato salad was what actually caused at least some of the illness. But you'd also, of course, need to do the same calculation looking for correlation with all the other foods, since it could be more than one of them. In this case, we find that people who ate the potato salad were 30 times more likely to become ill than those who didn't eat it. And as you see in that little box on the right, that's the odds ratio. The problem is, this is what I see in the countries that countries sometimes do with their BES data. They look at how many people gave each response, but they don't look for correlations. And that's key to figuring out what is driving the problem the most. So a large gap that I'm seeing then in BES data is for zero dose. I've not seen any studies that compared best survey responses of caregivers of zero dose children to those who have been fully immunized, to the caregivers of the fully immunized children. This may or may not identify specific types of drivers that are important to address to reach more zero dose children. And one solution would be to conduct multiple BES surveys, assuring an adequate sample of caregivers of zero dose children, and then to look for correlations. So how can we identify those correlations? Easily. I worked with the collaborators from Food for the Hungry to develop this easy to use tool to tabulate your BES survey data and other data really, to identify those correlations. This is what it looks like, and a full explanation of how to use it can be found by clicking the link or scanning that QR code. With this tool, you can cut and paste your data, from ODK into one worksheet of this. Use the setup button to just tell the program where to find the variable that you want to use for correlation and what the values would be. And then you would hit run to generate this table and to do all of this tabulation. It generates these statements like you see in the green highlighted row to show which responses actually correlate with being zero dose or fully immunized. For example, this shows that a lot of the things above did not correlate. But when we ask, have you ever been turned away when you tried to get your child vaccinated in this country, the non-doers were more likely, 2 times more likely to say, yes, I have been turned away, where non-doers conversely, or sorry, the doers conversely said, no, I've never been turned away. So if you have data in a spreadsheet, it should only take a few minutes to generate this sort of analysis using this particular tool. So I have a couple of recommendations based on this. First, conduct the full BES survey, including the gender questions and the areas where you work. And feel free to add a few questions to test your own hypotheses about what is driving zero dose in a given area. Second, use the recommended activities that I mentioned in that theory of change, focusing on the ones that are correlated with zero dose in the areas where you do the study. Third, try out this correlation tool the next time that you conduct a BES survey in your country. The link that I provided for that actually provides the tool and the guidance on how to use it. And let us know the results and publish them if possible. Fourth, if you're interested in conducting this sort of study and looking for correlations in zero dose communities where you're working, please contact Zazie Hummel and also me. Zazie is a top-notch Harvard student who is finishing an internship with Gabby this week, and they are interested in working with an organization that would like to do a survey on behavioral and social drivers of vaccination, looking specifically at those drivers and determinants that influence caregivers of zero-dose children. I may also be able to provide some support if you want to do this sort of study. Thank you very much.